And dear colleagues, at the outset, let me thank the organizers for giving me this opportunity. In fact, I am speaking after 2 years in a podium. The first issue is, what is the rationality of the triple therapy? Patients having a coronary intervention, we routinely give dual antiplatelet drugs. Patients with atrial fibrillation, we routinely give oral anticoagulant. So if both the things are present, it is just like an addition of these two that makes it a triple therapy. But the management of AF patients who undergo stent placement for an ACS is really challenging because of the hemorrhagic risk and the thrombotic risk. Both this, one need to make a very fine balance between these two. Hence, routine triple therapy is perhaps not good. Though it reduces the rate of ischemic events, the risk of bleeding is significantly increased compared with one or two agents. Addition of a single antiplatelet to an OAC increases the bleeding risk by 20 to 60%. And addition of DAPT to OAC increases it to 2 to 3-fold. Let us look at some of the evidences and trials which influenced our decision. From the Danish registry study, we found that the patients, AF patients with stable coronary artery disease, the risk of bleeding with VKA plus clopidogrel is more than VKA plus aspirin, which is more than VKA alone. But there was a similar risk of MI, coronary death, or thromboembolism. AF patients with acute MI, they had a bleeding risk, triple therapy more than VKA plus one antiplatelet, but there is no significant difference in the thromboembolic risk. In some of the VKA trial, patients on VKA undergoing PCI, West trial, ISA triple on AFCAS registry, West is the most important. In this particular study, patients receiving warfarin undergoing PCI were randomized to clopidogrel alone versus DAPT, and it was seen that the triple therapy caused a significantly increased bleeding. There's a higher bleeding and higher overall mortality, but the ischemic events were similar between the two groups. The ISA triple trial in patients with warfarin on aspirin with deaths were randomized to clopidogrel for 6 weeks versus 6 months. It showed that there is hardly any difference between bleeding and the thrombotic risk when it was given for 6 weeks versus 6 months. In NOAC versus VKA with antiplatelet agents in AF patients after PCI, we have 4 very important trials: Pioneer AF PCI, Redual PCI, Augustus, and Entrust AF PCI. In Pioneer, rivaroxaban 15 milligram plus clopidogrel. Second group was rivaroxaban 2.5 milligram BD plus DAPT, and third group was VKA plus DAPT. It showed that the rivaroxaban-based regimens reduce the bleeding compared to VKA and DAPT. But one issue is stroke prevention. Non-inferiority of rivaroxaban 15 milligram was not established in this trial. Stent thrombosis was similar. In Redual PCI, patients with AF who had undergone PCI were randomized to warfarin plus DAPT versus dabigatran plus clopidogrel mostly, and both the doses of dabigatran was used. It showed that dual therapy with dabigatran caused less bleeding. It was non-inferior to triple therapy for thromboembolic events. But again, one point of concern: stent thrombosis and MI was numerically more with dabigatran 110 milligram dose. A meta-analysis of 4 RCTs showed that the TIMI major or minor bleeding was reduced by 47% in the dual antiplatelet antithrombotic therapy arm versus triple therapy arm, and no difference in the major adverse cardiac events. In the Augustus trial, it's having a 2x2 factorial design, patients with AFib, with ACS undergoing PCI, and on clopidogrel, mostly, some patients, some of them were on ticagrelor as well. They were randomized to apixaban versus VKA, and each group was again randomized to aspirin versus matching placebo. It showed that the antithrombotic regimen with apixaban without aspirin resulted in less bleeding and fewer hospitalizations without significant difference in the incidence of ischemic events. Addition of aspirin only increased the bleeding without reducing any thrombotic events. In ENTRUST AFPCI, patients with edoxaban 60 milligram plus clopidogrel was compared with VK plus DAPT. Aspirin was given for 1 to 12 months. It showed that among patients with atrial fibrillation and recent PCI, edoxaban clopidogrel versus VKA and dual DAPT was non-inferior for bleeding and similar ischemic outcomes. In 2020, there is an expert consensus decision pathway of ACC. It was published in 2021. It showed that the peri-procedural antithrombotic management, they gave a very detailed outline of this particular issue, antithrombotic therapy in atrial fibrillation undergoing PCI. They divided them into two groups. What is the type, depending on the presentation, whether one is going for an elective or urgent PCI versus an emergent PCI. Elective and urgent means you can give some time to the patients. It should not be done immediately, whereas an emergent PCI should be done without any further delay. If the patient is on VKA, hold VKA until the INR is below 2 for a radial approach or below 1.5 for a femoral approach. If the patient is on a DOAC, hold DOAC usually for 24 to 48 hours, depending on whether you are going for a radial or a femoral approach. Initiate IV heparin if needed. Add aspirin. Clopidogrel is given in the cath lab after knowing the coronary anatomy, and initiate IV anticoagulants, heparin, bivalirudin, or low molecular weight heparin. Whereas the emergent PCI, if the patient is on DOAC, stop DOAC, load with aspirin, give clopidogrel, and initiate the anticoagulants. That is the recommendation, but the safety of it is a little concern. Second part is if the patient is on VKA, this part has not been dealt very clearly in that particular pathway. But the European guideline is more specific about it. They recommend that if the INR is more than 2.5, don't add any additional heparin. Only give aspirin, clopidogrel, and do the procedure. If the INR is below 2.5, give a low-dose heparin, or one can go for a bivalirudin and do the procedure. This is the table showing the holding of DOACs before elective PCI. In all the 4 molecules which are approved, it is more than 24 hours for a radial approach and more than 48 hours for a femoral approach, provided there is no renal dysfunction. The renal dysfunction increases this waiting. Regarding the reinitiation of the oral anticoagulants after PCI, DOACs are preferred. If a direct oral anticoagulant is given, administer aspirin low dose at least for 1 day. And if VK is restarted, one should consider a bridging with low molecular weight heparin for high thrombogenic, if the patient is having a high thromboembolic risk. Otherwise, add aspirin low dose till the INR is in the therapeutic range. Continue P2Y12 inhibitors, and it is better to start a PPI or H2 blockers. One can continue aspirin low dose for up to 30 days if there is an increased thrombotic risk but a low bleeding risk. Regarding the Post-discharge medications, PCI for stable ischemic heart disease, continue P2Y12 inhibitor for 6 months. Next 6 months, you can continue either P2Y12 or switch to aspirin. Oral anticoagulants to be continued for 12 months, and after 12 months, stop antiplatelet drugs and continue with oral anticoagulants. For PCI, continue clopidogrel and oral anticoagulants for 12 months, and after that, stop clopidogrel and continue with oral anticoagulants. There is another consensus statement by Deepak Bhatt and his team, which is almost similar, but there is the only difference is in patients at low ischemic but very high bleeding risk, they have recommended to continue the double therapy for 6 months of a clopidogrel and an oral anticoagulant, and after 6 months, only oral anticoagulant has been recommended. Let us see the European perspective. They have identified the thrombotic risk, bleeding risk factors, and the strategies to reduce the bleeding, like a radial approach, initiating PPIs, not administering heparin if the INR is more than 2.5, etc. And this slide tells everything about the European guideline. ACS patients on oral anticoagulants, if the patient is on VKA, look at the INR. If it is below 2.5, heparin has to be given. If the patient is on NOAC, heparin has to be given. After the procedure, continue NOAC indefinitely. P2Y12 inhibitor to be continued for 1 year, routinely. If the patient is having an enhanced bleeding risk, it can be shortened to 6 months. I will take another 2 minutes. Aspirin to be given only during the peri-procedure period, that is up to 7 days routinely. But beyond that, in patients with increased thrombotic risk but low bleeding risk, it can be extended up to 1 month, but not beyond 1 month. For medically treated patients, NOACs to be given long term, with a single antiplatelet drug, clopidogrel, to be given up to 6 months. Patients with chronic coronary syndrome, if the patient is on VK and INR is below 2.5, one need to give heparin. If the patient is on NOAC, one need to give heparin and continue NOACs or VK indefinitely. P2Y12 inhibitors to be given up to 6 months routinely, but in presence of increased bleeding risk, may be shortened to 3 months. Aspirin, just like the ACS, to be given during the perioperative period only, or in presence of increased thrombotic risk, may be extended up to 1 month. This is a summary of ACC Expert Consensus 2020. In general, use of triple therapy is not recommended for patients due to an increased risk of bleeding. If triple therapy is needed, a short duration, not more than 30 days, is recommended. When combined with an anticoagulant, clopidogrel is the recommended antiplatelet agent for most patients. If aspirin is used, it should be limited to below 100 milligram. For patients taking 2 or more antithrombotic agents, starting or continuing a PPI and avoiding other anti-inflammatory medications should be employed to reduce the GI bleeding risk. Oral anticoagulants plus P2Y12 inhibitors combination is recommended for the first 6 to 12 months, potentially switching to P2Y12 to aspirin for the months 6 to 12 if PCI in stable ischemic heart disease, followed by anticoagulation monotherapy after 12 months. Use of a DOAC is preferred over VKA when appropriate. For patients taking DOAC medications who require PCI, most DOACs can be held for no more than 36 to 48 hours prior to the procedure. Holding a DOAC for longer period of time may be required for patients with moderate or severe renal dysfunction, especially if using dabigatran. When used in combination with antiplatelet medication, Dosing of DOAC medication usually follows the FDA guidance for stroke prevention in AF or treatment of VTE. However, rivaroxaban may be administered at 15 milligram per day or reduced to 10 milligram in presence of renal dysfunction when combined with P2Y12 inhibitors based on Pioneer AF trial. This is last slide. There are a few areas of concern. Is triple therapy mandatory? Particularly, what is the role of aspirin in presence of P2Y12 inhibitors? Whether NOAC plus P2Y12 inhibitor sufficiently protects against stent thrombosis or MI. All these trials are underpowered to answer this question. Is 15 milligram rivaroxaban sufficient for stroke prevention? There is doubt in it. Increased incidence of MI and stent thrombosis in 110 milligram BD dose of dabigatran in redual PCI, it raises concern. Whether NOAC plus aspirin, an alternative to NOAC plus P2Y12 inhibitor, there is no randomized control trial. Safety of ticagrelor and prasugrel with oral anticoagulants is not established. In VKA-treated patient, PCI is safe without bridging and without additional peri-procedure heparin. What about the NOACs? Thank you very much for your patience.